pregnancy, smoking in pregnancy and COVID, which again is available on the website, and hopefully you've already seen. And then a further sort of poster or handout for parents in relation to smoking and coronavirus, which hopefully people are using and are finding useful. And do give us feedback on these documents as to how you're using them and you know, the value that you're getting from them. We've also written this more detailed advice, guidance for local maternity systems around smoking in pregnancy and COVID, which hopefully again you've seen and is proving useful. I'm remembering by looking at this slide that Vicky wanted me to say something in particular when I got to this slide and I've forgotten what it is. Vicky, what was I supposed to say?
Hi everyone, so this is just that on the back of this two-sided document, we offer to put you all in touch with any local authority public health team contacts around tobacco as well, and a few people have taken up that offer, so do get in touch if you want to know who the local authority contacts are.
Thank you, and I think that's the end of my slides, so I will pause there and we can move on to those people who are going to talk in more specific detail about what's happening in maternity services.
Thanks, Hazel. We will now hand over to Martyn, who, as Hazel said, is going to be talking a bit more about NRT and addressing some of the local challenges brought about by the current situation. I'll hand over to Martyn.
Good morning, everybody. I've just been told I'm unmuted, so I'll start that again. I don't have a slide set this morning, but I do have one holding slide. And as both Vicky and Hazel have mentioned, I'm going to talk a little bit about managing NRT supply during these challenging times. Before I dive into that, though, I just really, on behalf of PHE, kind of endorse the Quit for COVID campaign. Some really good resources have come out from that. And they also supplement hopefully people saw a few weeks ago at the end of March from the National Centre for Smoking Cessation and Training, which pushed out the guidance about pausing face-to-face behavioural support, but re-emphasising the importance of continuing to deliver that support remotely in combination with the supply of NRT or appropriate products. And I know that Lisa's going to talk a little bit more about the behavioural support side of things after me. I'd also like to very quickly flag up two forthcoming documents or publications that I think are relevant. The other one is also from the NCSCT, National Centre for Smoking Cessation and Training, and we'll look to pull together some best practice evidence around how to deliver that behavioural support remotely. And I've seen an early draft of that, and that looks really good and will hopefully be available shortly. And from PHE itself, we've been working for a little while now on some key messages around smoking in relation to COVID and things like relative risk. As I'm sure colleagues will appreciate, this is a fast-moving field. We've been very fortunate to have support from UCL, University College London, who've been undertaking a rapid review of all the evidence around smoking and COVID, and we're trying to pull that together into a coherent set of messages. At the moment, that's literally with the Chief Medical Officer for final sign-off. So hopefully that will be coming out shortly. But the main thing I've been asked to talk about today is looking at NRT supply at the moment. And before I get into some specifics around that, there's probably two things to mention up front. Firstly, I'm going to talk about local supply of NRT rather than any issues about availability of NRT at a national level. I've heard one or two instances about local pharmacies where they've been struggling to get hold of stock itself. It seems, fortunately, as though these are local issues in some of our most rural parts of the country, but I'm always interested to hear of any examples where literally pharmacies themselves aren't able to get hold of any stock. So that would be interesting to know. And the second thing is a document that has already come out, and that was launched on Friday. And that addresses this specific issue about some looking at some really good local practice around provision of NRT during the pandemic, coupled with examples of good practice around delivering behavioural support. So we work really closely with our PHE centre leads and with local authority leads on this. And thank you, because I know some of them are on the call today. Thank you to those that came forward with some exemplars of good practice. They've been included in that document, along with contact details. So if people want to talk to those local leads and learn a little bit more about their programs, then they're able to do so. So that document went out on Friday via our centre leads. I know that the Smoke Free Action Coalition sent it out to local authority leads on Friday too. And speaking to Hazel and Vicky before this webinar, they've agreed that we can send that document out directly to everybody on the call today. So in terms of what NRT supply looks like at the moment, given the lack of face-to-face behavioural support, many of the exemplars that we've been sent focus around postage of NRT, whether that be direct postage from a pharmacy or from the Stop Smoking service, or even hand delivery from various NHS colleagues. But postal delivery seems to be the nub of how most localities are getting around this. And I guess there's one key consideration for us at PHE around this, and it's about ensuring that we're complying with the legal requirements around safe delivery of NRT. And the key consideration with all of this is how the NRT is being stored. So if it's stored in a secure pharmacy and then posted out and delivered out from there, that's not an issue. Equally, if the NRT is being stored in a clinical setting in a locked cupboard and it's been delivered directly from there to the end user, that's also within the law. Clearly, and we've heard no instances of this at the moment, but it's something we want to be watchful about. Clearly, storing NRT at individuals' home, however well-intentioned that might be, even in a secure setting, in a secure cupboard at home, and then delivering it or posting it out from there, would not be compliant with the law. So that's something we're always really mindful of. So the document that we sent out on Friday mentioned looks at the delivery of NRT, and it looks at that in various clinical settings. So for instance, around mental health settings, but also there are a couple of key examples there around maternity settings too. And I just want to draw out a couple of the examples that I think are representative of what many localities are doing. So for instance, Lambeth and Sheffield have, I think, quite typical of other places, have traditionally operated a voucher system whereby, as part of the behavioural support consultation between an advisor and a smoker, as part of that, they would be given a physical voucher that they could then go to the pharmacy and exchange for their NRT products. Clearly, as there's no face-to-face behavioural support happening at the moment, Lambeth and Sheffield have replaced the physical voucher with an e-voucher that they email following the remote consultation to a local pharmacy, and then the clients can either pick up that product directly from the pharmacy, or it can be posted out either using the Royal Mail or could be delivered by pharmacy staff, or in some instances the Stop Smoking service are using their staff to pick up products from pharmacy and deliver it to the client directly. North Yorkshire are doing something very similar, but as well as using the e-voucher, they also have a paper voucher as a backup in case that doesn't work, and they can post that to the pharmacy. Interestingly, they are using NHS volunteers, which are clearly targeted at the kind of the more susceptible in society and those that are being shielded, and they are using the NHS volunteers to deliver that NRT product directly to the end user. York, I think, are typical of a number of other places in as much as they are operating a direct supply of NRT, so they purchase NRT products directly from a supplier and could physically hand it over to the clients in previous times. But clearly, as I say, they're not seeing clients face to face at the moment, so they too are either using postal service, although there have been some delays with that. So they've also introduced a system whereby they're currently using health trainers to physically deliver the products. And I think it's important just to reiterate at this point, when using health trainers or stop smoking advisors or NHS volunteers to deliver products, in essence, when doing that, they are replacing the normal postal service. So they're not going to people's home and delivering stop smoking messages or spending any time at people's home, but they're literally just dropping off the products and delivering it to the end user. Warwickshire is one of those places that flagged up they've introduced something specific around maternity, and they've introduced a 4-month window of opportunity where they will be posting out NRT directly to pregnant women on the back of their initial consultations. Hazel touched briefly upon availability of e-cigarettes and vapes, and again with the usual caveats around smoking in pregnancy and pregnant women, where e-cigarettes are not a first line of products, but we should encourage women who are adamant that they want to use an e-cigarette and an e-cigarette is going to support them to remain smoke-free. We should encourage them to use e-cigarettes and advise them accordingly. So there was an interesting national discussion about whether vape shops should be designated as an essential service. The government and Department of Health advised that was not the case, so vape shops should not be open and functioning as normal, but clearly many vape shops have an online presence, and some of them have introduced delivery services themselves. So I know that a couple of local authorities, for instance, I think Devon and Plymouth were two such, have introduced engagement with local vape shops and with the IBVTA, which would flag up as the Independent British Vaping Trade Association, that have put some really good guidance on their websites about protocols in supplying e-cigarettes during the pandemic. So I would probably draw a line under it there, just to flag up again, this document that came out on Friday has a number of kind of practical local examples of NRT supply. We'll make sure that it's shared with everybody on the call, and as part of that, there are contact details for local leads that have said that they're happy to talk with others about how to set up these supply chains in what are clearly difficult times. Thank you.
Brilliant. Thank you, Martyn, for that. Just as a reminder to everybody, do send in your questions using that panel along the right-hand side of your screen. We've got a few questions coming in now for Martyn, so we'll have a chance to put them to the speakers once we've heard from Lisa, who is going to be talking about adapting that evidence-based pathway of support during COVID-19. So Lisa, I'll hand over to you.
Hi, good morning everyone. It's lovely to have this opportunity today to share all this wonderful information and look at ways of supporting pregnant smokers during this really difficult time. So just a little bit of background from my perspective. I've been working with Hilary Waring, IPIP at the team, and we've been working closely over many months to support Greater Manchester to implement the Baby Clear approach, which, as many of you will know, is an evidence-based, effective whole systems approach to tackling and reducing smoking in pregnancy. And we've continued to support and deliver training quite recently to make sure that the advisors get what they need, as well as the pregnant smokers. And we were really keen to better understand some of the challenges that people were facing whilst doing this very important work remotely. So saving babies' lives is still very high on the agenda, and it hasn't changed anything just because we've got COVID-19. But what it means is, as Hazel mentioned, the women are far more at risk. If they become sick, they're more likely to have serious complications and be hospitalised. And stopping smoking has never, ever been so much more important than now. So we're going to spend a bit of time looking at some of the information that we gathered from the advisors, some insight work about how women are feeling at the moment about stopping smoking, some of the barriers that advisors are facing, but more importantly, how we can engage and empower them during this really difficult time by Skype, by telephone, which we know historically bring about lower quit rates, but we still need to press on with this very important message that giving up smoking is the best thing they can do for their baby and the one thing they can make a difference of. So we'll have a look at what's on the agenda. Okay, so I don't know why I can't forward my slides. Can you help me with that, John?
Lisa, if you
Can
just
you...
click.
That's it.
Oh,
Okay.
there we go, that's worked.
That's working now, thank you. So we're all learning, you see, it's all very different. So what we're going to do is we're going to look at some of the insights that we got back from the advisors in Greater Manchester and other areas since then, which the challenge group has fed back. And thank you for everyone for sharing that. And then go back to basics and revisit some of those key skills required to engage smokers. And let's face it, you know, pregnant women are a very tough nut to crack. They've always been very, very difficult to engage. And I know, because I've been out there and done the work myself, I've worked as a specialist in Doncaster and Rotherham, so I understand the challenges out there. But motivational techniques can really help with those difficult times, in the moments when you feel that the conversation is going nowhere, when clients seem very distant and challenging, when it feels that you've lost them. So we're going to have a look at that, and I've included some heart sinks towards the end of the PowerPoint that some of the feedback brought to us, that we think we can sort of give some ideas of questions that you could ask that would help maintain that dialogue. So women, it would appear, are facing challenges with many, many things. Advisors have told us that they're not stopping altogether, they're cutting down, or they're still just having the odd cigarette. They're worried about money. People are smoking around them. They may be in lockdown with people they didn't live with before but have chosen to lock down together, or the people around them are spending much more time around them still smoking. That doesn't help with quits. Domestic violence, so I'm imagining the helplines have received an awful lot of calls, and the need for support and help with that is greater than ever. So women have lived with these problems before COVID and will live with them after COVID. But of course, what we're now finding is that the women are sharing these experiences more readily with the advisors that are calling them about smoking. They're worried, they're anxious, they're worried about the pregnancy. So they are sharing sort of maternity issues and antenatal problems with advisors that may not be skilled to deal with that. So we're going to come back to that one as well. So advisors are facing the challenges of with not being able to see clients face to face and building that positive relationship, which we know is so important. But it's no wonder, is it, when we think that, you know, these women are now not getting the routine CO testing at the hospital. They may not have already received a deeper intervention with the midwives about smoking, but they're still being referred on the opt-out system. So when you get through to them on the phone, it's no wonder that it's difficult and they are putting up many barriers because they haven't already thought about quitting smoking and may not, as I say, you haven't got that platform to build on that you ordinarily would had they had some input from the hospital. So what we need to do is look at behaviour change and how we can support women to make those more important and positive changes. Many of you will have completed the 2-day course with us before in Baby Clear, and we do cover sort of motivational work and do a bit of a workshop. So for people that have done Baby Clear training, this will be familiar to you. For those of you who haven't, you may be able to take away some new ideas and approaches, which will be great. Now, it says on every cigarette packet that smoking is harmful. We know that smoking causes great harm to babies. Women will tell you they know that it's harmful. But the question is, do they know the true harm of smoking? I think many of us already have learned from talking to women that they do not know the true harm. They'll tell you that it's bad, that they know that they shouldn't be doing it. But when you ask them of the problems that can arise, they often tell you they're not sure. They think a small baby will be okay. They're not worried about having a baby that's born a bit too soon because they believe that we can work wonders on the special care baby units. So in actual fact, they are not still learning the great harm and believing that it's never going to happen to them. So, and I think I can liken it a little bit to if my car made a bit of a strange noise, I'm not a mechanic, I'd sort of probably carry on driving thinking it's going to be okay. And, you know, when it breaks down and it's at the side of the road and everything's gone horribly wrong and the mechanic comes and lifts up the lid, I have no idea of what I am looking at because I'm a midwife, not a mechanic. And then he tells me what happened when the noise came and then something else went wrong. And I realised I should have stopped a lot sooner. I would have caused less damage and it would have been a lot cheaper to repair, no doubt. But it's like that with the pregnant women. It's only when they learn of the great harm and how things go wrong, they realise the importance of quitting and are maybe willing to do something about it sooner rather than later. So every time you're talking to pregnant women, remember they are not midwives, they don't have the knowledge that you have as advisors, and they do not know the great harm of smoking. We don't all follow good advice either. I don't follow all this good advice. It can be really important to know what's healthy, but lots of things get in the way of carrying it out. They prevent us from actually doing it. So there's a difference between knowing something and really grasping it and feeling it in your bones. You'll have already observed that direct persuasion doesn't make people change. Telling somebody simply to stop smoking doesn't make it happen. You'll have all experienced this in your life as well. Being told what to do can actually make somebody far more resistant to change. But we want to be helpful. We sense the urgency of the problem. We've got this window of opportunity to get somebody to quit smoking. So we are very keen to make sure that women try and quit before 15 weeks of pregnancy. But when we step in and tell people what to do, it can increase the resistance and likely disengage the woman from the conversation, and she may not be very responsive. Put the phone down and then you can't get her back on the line. So we need to be very mindful of not telling people what to do. If you're a clinician by background, a nurse, a midwife, a health visitor, you'll find that it's very hard not to give good advice. And I can remember seeing clients in the very early days, 20 years ago, where you start telling them what to do and they seem really responsive. They're nodding and smiling and saying all the right things. But in actual fact, they were hearing nothing. They were not buying into what I had to sell. They weren't ready to make this change. So I was all very surprised when they didn't come back for the next appointment or take the next call. So I think our approach has to be different, and we need to approach it in a way with questions that will make that woman think more deeply about the choices she's made. And we need to be a bit of a detective, really, and get to know this person and build the rapport and find out and understand things from her perspective. Now, we know that women can feel nagged or judged when they're being told what to do, or when we're talking about the risk of smoking. And that makes things very difficult for us. It's very easy to launch into the talk and try and offer and sell what it is we have from our little toolkit, which is all our knowledge and skills and medication around cessation. But we can be met with great resistance. And some advisors have told us that clients have even been plain rude to them. You can get yourself into the tennis match. We offer some really good advice when the client seems to be struggling, but it's thrown back at us. It's not a good suggestion. So we try something else and the ball is thrown back again. Before we know it, we exhaust ourselves into trying to solve what actually is the client's problem, not ours. And the client can feel that you're not doing a very good job and not saying anything very helpful and believing that this thing is far too difficult to achieve. So remember, women are gods of their own world. All smokers have many reasons for their continued smoking. They are the expert in knowing what works and what doesn't, why they smoke, why they'd like to quit. They have the most power to be able to make the change, of coming up with an idea of what to do, and have the most experience of thinking of something that might be realistic and achievable. They're more likely to go away and think of and put into action something they thought of rather than something we came up with. So we don't want to be giving good advice, but rather try and ask something that plants a seed of thought in their mind, something that can penetrate all the things that keep them smoking. Just say something that will make a difference. So asking questions is the one thing that will make people think. It can really encourage them to have new thoughts and ideas. This can be the start of change. So some ideas of questions would be things like, tell me what you've heard about smoking and pregnancy. How do you feel about your smoking now that you're pregnant? Had you had any plans before lockdown to quit smoking? How has it changed? So just a bit of a summary of what we need to be doing is listening with no agenda. Remember, women do not answer the phone and automatically want to quit smoking. Despite having a bit of talk at the hospital and a referral, they may not have had anything deeper than, that sort of form filling and the information being sent in for you to then give them a call. So we need to go in there with no advice and be very open-minded, listen to what it is they have to say, and ask lots of questions. Be a detective. Information-seeking questions are very easy. So how many do you smoke? Have you ever tried to quit before? But the thought-provoking ones are the things that can really help the speaker think. Now, a question would be, have you ever tried to quit smoking before? Yes, I have. Tell me what happened. What made you go back to smoking? How did it make you feel when you didn't achieve what you set out to do? What are the main things getting in the way of stopping smoking? Questions like that can really, really help. Feedback is also very important, and I think possibly it's the one thing that people forget to do. And it's just really feeding back all the facts as you've heard them. And it could be just a whole tirade of problems. Oh, the kids are under my feet. My husband's at home all the time. I'm worried about money. I can't get to the hospital. It's just feeding back all the things that you see as their dilemma, not trying to sort it out or solve it, but just feeding back the areas that they're really stuck in. Picking up on any hunches. So it may be that you pick up that they're worried about smoking, but have many reasons for carrying on. So an example would be, it sounds like you're really worried about smoking and the effect on the baby. You've tried quitting before and it was really difficult, and people are still smoking around you now, so that makes it really tough. You'd like to try again, but fear that the stress will get in the way. You're stuck at home all day now with the kids, and your partner isn't earning any money. And then you just stop and wait a moment. Often in the silence, people are willing to share a little bit more. They come back with some more information. The conversation can be a little bit more relaxed. They trust you. You've heard them. You've listened. You're not telling them what to do. And they feel a lot happier about sharing a little bit more. So this really helps to build the rapport as well. So feedback is really important and can really encourage that client to open up. And summarising really just clarifies the main points of what the client is saying, reflecting it back. And it can allow the client a bit of time to recap. And it makes sure that you've heard everything properly too. That's important. I can remember working with a lady once, and she told me, oh, but the midwife told me that the smoking was bad. But I think that's actually a good thing for the baby. And when I asked her why, she said, oh, because the baby's heartbeat goes far more quickly when you smoke a cigarette. I said, yeah, that's true. She said, well, I figure then when the baby's born, there'll be a lot of oxygen around and the baby will be super fit. So she'd heard a little bit of what the midwife said, but she hadn't had it checked out what her interpretation of that was. And this is just something that reflects that. To stay young, the doctor said to exercise and eat the right foods. And a friend said, all right, I thought he said accessorize and buy nice shoes. So women can often hear things very differently to how they're being said, and they may not grasp the importance or the points to what you're making. So the summarising can really help. So let's have a look at some of the heart sync moments then, the heart sync statements that you've sent in, the things that you were really worried about. Some people have said that women are saying they've not felt the baby much, or they may have had a bit of abdominal pain or a bit of bleeding, and they're not accessing the help at the hospital and the support from the midwives. So they're worried about the pregnancy, and that the stress makes it hard to quit smoking. They're saying it's really hard. Their partner's at home all the time. They haven't got a job. They're worried about money. They're stuck in the house, and maybe domestic violence, so lashing out at me. The kids are under my feet. They're not at school now. The stress is so bad, and smoking really helps me cope with stress. And some people have revealed that women haven't quite stopped. I'm just having the odd one, that one in the morning, just that one in the evening with my partner. I've almost done it, but I'm not quite there. Let's have a look at how we could tackle some of those. So I think we need to be aware that when women are telling us that something isn't quite right with the pregnancy, the baby isn't moving, they've got some pain, we need to make sure that they are accessing the right help and support. You're not a midwife, you're not an expert in the field, and that's fine. You're there to listen and direct them to the places that can support and help them. We know for a fact that they've had a 75% increased calls to Tommy's helpline during the lockdown period, because women are afraid to access help at the hospital. They're afraid to go in. They're worried about the coronavirus. And even when they fear they're having a miscarriage, the evidence is that they're not accessing the support. So asking questions, you know, have you spoken to the midwife about this problem? What's made it difficult for you to contact the midwife? Do you have a number? Telling them they can always call the hospital to speak to somebody who can talk to them, advise them, and bring them in if necessary. There's always somebody up on labour ward. We used to get calls day and night up there and then filter the call to the right person. So always tell them at 2 o'clock in the night, if they need some help, they can ring the hospital. So assure them it's important to get the medical advice, but then bring it back to the smoking. You can ask them what they know about the harm of smoking when pregnant. We know that it's related to miscarriages and babies not moving properly, babies not growing properly. And this is an opportunity when they're not sure to ask if you can explain what happens and relate it to the baby not moving and growth, and letting them know that the small baby is a weak and poorly baby, an underdeveloped baby, a baby that is so much more at risk during the pregnancy and after birth. And you can link it with the concerns that she already has, and obviously then go on to explore the benefits of stopping to the baby, which is helping that baby to grow properly and have a much safer delivery, and not be having these worries during pregnancy when they're frightened to go into the hospital. This one, the partner situation, the bad-tempered partner, I think it's important that we do have local resources, numbers, helplines that we can direct them to. Again, we're not an expert in the field, but asking questions like, how long has it been going on for? Do you have anywhere to go if you feel you're in danger? Who could help you with this? They are allowed to go somewhere else during this time. Can they pull on somebody else who can help them? And offer something for them to call, a helpline, a number, and always let them know that you're there to listen. But of course, women had these problems before coronavirus. They lived with partners that were bad-tempered. They had children at home they couldn't cope with. They were worried about money and poor housing. They will have always had times when they couldn't smoke and they've tried to manage. Ask them, what techniques have you tried before when you couldn't smoke and you were in a really difficult situation? Help them to see that there were moments when they could survive it, that nicotine withdrawal. Ask them what they developed, what coping strategies they had in place, and help them to see that they can be in control, that they can manage difficult situations, and give them some confidence. So you could use that as an opportunity there. Kids getting under their feet, stressing them out, that's a very common one that's come out actually, because women tend to smoke, smokers smoke when they're stressed. The thing is, we know that often those feelings are withdrawals, and asking them if they've ever had those feelings before when the kids weren't playing up and their partner wasn't being difficult probably will allow you then to talk about withdrawal symptoms. And they smoke, it goes away for a short time, but then it comes back. And you can talk about nicotine, because what we're really keen to do is let them know we want to take away the tobacco, which is the thing that puts them at most risk during this really difficult time and not help their babies. But the nicotine is very safe. We can give them back what they really need, the one thing that makes them happy, the one thing they need when they find themselves in these horrible moments and situations. So taking away tobacco, but giving you back the nicotine to help you cope, to help you feel less stressed, and to help you manage those day-to-day moments. Almost stopped. Well, I think we need to touch on the not a puff rule. Again, we know it's so important that people that still smoke after quit day are far more likely to go back to regular smoking. But asking questions like, you know, why haven't you managed to stop altogether? What's getting in the way? What do you think will happen if you don't manage to get rid of that last cigarette? And letting them know that people are far more likely to go back to regular smoking. It will soon be back to 10 or 20 a day, because you are reminding your body and your brain of all the things that it was missing. And it's very hard. Those withdrawal symptoms are still very powerful, and you will not be able to cope with just a few weeks of medication when you're still putting cigarettes into the equation. Cutting down, just to remind you, we do not do cut down on medication, so no cut down to quit in pregnancy, and we don't congratulate people that have cut down, but respond in a way that's positive. So you've cut down your smoking, tell me why, talking hopefully about the risks of smoking pregnancy, and then asking them what their plans are to quit altogether. What's the main thing getting in the way? And what do they see as the big problems around those remaining cigarettes? Remember, midwives are able to do that deeper intervention at the hospital. There are staff shortages. They're trying to get the women through the clinics more quickly, and appointments are being cancelled. So don't make the assumption when you make the call that the woman has had time to buy into the idea of the thing that you're selling, which is smoking cessation. Enter the conversation with no agenda. Enter it as a way of just having a chat with somebody, learning a bit more about them, finding out what the situation is at home, finding out what they understand about the harm. There are people still around her telling her it will all be okay, that cutting down is acceptable, that small babies aren't a problem. So find out what she knows, what she's heard, what does she understand, put right the misinformation, and then go on to talk about what smoking cessation would mean, what could it look like, and what you can offer. Just to think as well, now we're doing more conversations by Skype, FaceTime and telephone, because I've made a few errors over the past couple of weeks when I've been doing Zoom calls and all sorts, but looking at the camera, not the screen, to help maintain that direct contact. Dressing part, my sister had a call the other day with work and forgot she was in her pajamas, which made me laugh. Prepare your surroundings, make sure you're in a room that's quiet, close programs on your computer. Use notes if needed and reminders as a prompt. You can have a cheat sheet, but you need to avoid any interruptions from phones and dogs barking and everything else. And your body language is so important if they can see you, to look that you're sitting, you need to be comfortable and not fidgeting around halfway through the appointment, because that can be very distracting and disruptive. But think about the other resources that Martyn and Hazel have spoke about today. Make sure you've got those helpline numbers to give out, and make sure that they can access the information that they want. So just some more sort of open questions that you can use, and certainly bring in the conversation about the coronavirus. What have they heard about the risks now that this is around? Do they feel worried about it? And just say, I'd like to explain a little bit more now about what we know.
Lisa,
so remember, oh yeah, sorry, I know I'm running out of
2 minutes. There we go.
Yeah, this is the very last slide. So remember, you're safe to listen. You can have a good relationship still. You don't have all the answers. You don't need to get out of your depth with things you do not have the expertise to solve. You can, though, listen, direct to other help, not tell them what to do, and help them with this brilliant opportunity. See it as an opportunity, not a barrier, to now more than ever help get rid of tobacco with COVID being around, and make it a safe place and give them what they need, which is the nicotine, to cope, feel happier, and help their babies grow safely. Thank you.
Thank you, Lisa. That was all really, really helpful. And we've got some really positive feedback coming through from people on the line there. So we've just got a few minutes. I'm going to start with one that's come through from a few people in different ways, and possibly be one for you to start on, and then maybe Lisa if she wants to add. And this is about the idea that's been sort of shared online and in media at the moment, that nicotine could offer some protection against COVID-19, and therefore women saying that smoking could be protecting them from getting COVID-19. So some questions around what the truth of that is. Hazel, I don't know if you want to kick us off there, and then perhaps hand on to others.
Yeah, I mean, it's a tricky one, because obviously this is, as I said at the beginning of my presentation, we have this novel virus, and there are lots of things we don't know about it. So there is, and there's lots of data being gathered, there's lots of stuff being published, but the quality of some of that information is quite variable, and some of that's completely understandable. Collecting data in an emergency situation is tricky. So some of the reports around nicotine and coronavirus have come from the fact that there are studies that seem to have shown an underrepresentation of smokers being, for example, hospitalized in some countries. I would say that there's an ongoing, I think they're calling it a living review, that UCL are leading, which is putting together all the evidence from around the world on this. And their conclusion is that the quality of the evidence at the moment is very poor. So it's really difficult to draw any conclusions because smoking status isn't necessarily being captured appropriately, or there are all sorts of reasons why there's problems with the information. But what I think we can say is that there are many, many reasons to quit smoking. There is no evidence that smoking is protective in relation to coronavirus, and there is certainly evidence that those smokers who are in hospital progress to more severe diseases. If anything, if the hypothesis that nicotine could be protective, and it is a hypothesis, would have any validity, then what it points smokers to is the need to use alternative sources of nicotine as a way of quitting smoking, because we know there are immediate benefits to quitting smoking across a whole range of conditions, and that's particularly true in pregnancy, and that sources of nicotine like NRT are safe, and that those are what people should be using because it will help them quit smoking. And if there is any validity to this hypothesis around nicotine, then you get the benefit from using the NRT. I hope that's helpful. Martyn, you might want to add something to that. I don't know.
I'm not sure there's an awful lot to add to it, Hazel, because I think you've covered it well there. I would reiterate the rapid review that we are using as PHE as well, and maybe that there's a link there we can send out to our colleagues on the call, and that exactly as you said, Hazel, that kind of looks at all the research that's coming in rapidly at the moment and looks at the strength of it. I think it's interesting the amount of press coverage that one study generated, or maybe it's not surprising, but I think it's important to distinguish between what that study was looking at nicotine use as opposed to smoking, and I think we need to be really clear on our key messages that there's evidence out there that smokers will have more severe symptoms of COVID. I think the evidence is coalescing quite clearly around that message now. So it's an important time to stop.
So the other resource as well is the FAQ document that's been produced to go alongside the Quit for COVID campaign, which again, I think if we circulate that with the other information from this webinar, which has been reviewed by some of the leading experts on tobacco in the country. So it is kind of written in plain English as well. So would be a useful resource for people.
Great, thank you. And Martyn, I think there's one more that's coming away here, which is around whether there are any shortages of nicotine patches. So this is from an area which is requesting prescriptions from GPs and using pharma outcomes to raise codes with pharmacies for NRT, and then an addendum to whether most areas are posting out just weekly supplies of NRT, or whether it's a good idea to be giving out larger quantities at the moment so people are secure in that supply.
Okay, I touched very briefly at the start about issues to do with availability of NRT and indeed Champix, and we've not been hearing of any national shortages. What we have heard is some isolated pockets, and it tends to be the examples I've heard from some of our more rural pharmacies that have been having troubles with their local supply of NRT. That's not to say that there might not be something happening, and I'd certainly be keen to hear of any such examples, but it's not something that we're seeing nationally at the moment in terms of shortages of specific products. On the point about supply and length of supply, I would probably urge services not to deviate too much from what their typical practice is, whether that be 1 week supply. I certainly wouldn't encourage more than 2-week supply of products to be given out at a certain time. I understand the attraction of giving out more supply, but I think we should stick to no more than 2 weeks. It also prompts a thought in my head, a question that we have been asked about services opening up packets of NRT to make them easier to package and send out. Unfortunately, the advice that we've had from our pharmaceutical colleagues and colleagues in DH and PHE is that that's not appropriate to be sending out products that have already been where the packaging, the outer packaging has already been opened.
Brilliant, Martyn. A couple of questions here now around the impact that stopping or pausing CO monitoring is having, and that being linked to a decline in referrals for specialist support, and also a decline in the number of women taking up referrals where they are being made. Lisa, I wonder if you want to come in on that around the rest of the pathway and that motivation for getting women into services.
Yeah, it is. It's very difficult because we know that routine CO testing is such a powerful intervention, because at that moment the midwife can describe the harm of carbon monoxide, not smoking, but the harm of carbon monoxide on a baby. And that actually really helps us to make that referral, enable that woman to pick up the phone. Now, I don't know what's happening out there at the moment on the front line in the clinics and what the midwives are managing to have time to say, but I'm imagining without the CO test and showing her the great harm, that is having less of an impact now when the advisors call. And that's why I think I just refer back to, when you call the women, ask them what the midwife said to them. Ask them what they know about carbon monoxide, because we could do that conversation on the telephone. So what have you heard about it? What do you know it comes from? And then you talk about how it reduces oxygen to babies and makes them small, weak, poorly, underdeveloped, and more likely to get sick and not even make it. These are the sort of powerful language that we can use, but just by going in and asking the questions rather than going in with all of the spiel, allowing the woman, just say, a lot of people haven't heard, a lot of people aren't sure. We now know that the carbon monoxide test can't be done, but I'd really just like to share some information with you and find out what you know. And this would bring about the little bit that was missing from the hospital.
Great, thank you, Lisa. And similarly, there's a question here around whether this COVID-19 situation has highlighted the need to improve training for midwives and all maternity care providers to ensure that women are engaged with services and that they are delivering the right sort of messages in those first appointments. I think as the challenge group, we would certainly say that all staff should be having this training, and that it should be a core part of their sort of training proficiencies as a midwife. Again, Lisa, I don't know if you want to pick up on that, as this training is part of your.
I think it's a really difficult time to deliver any training. We've certainly done a lot online, and we are managing to do that. And I think midwives and other health professionals are really keen to know everything they can about COVID-19 and relate it to specific topics. And smoking is a really important one, and what they could do to make a difference when they're seeing the women in the hospitals. We do know that when we're not sure about something, we tend to not talk about it. And when we're not in full possession of the facts, we don't want to make a mistake. So more than ever, we do need to get that information out there. We need to help and empower midwives and other health professionals to raise the topic and make sure that we're giving the right information and making sure that the women receive it, and then and use it to empower them into making these more positive choices. We haven't got a CO machine to use at the moment, but we can certainly use COVID-19 as a lever into the conversation.
Brilliant, thank you, Lisa. We've got a couple of comments coming in here, Martyn, around pharmacy supplies and where there are reported issues, so we'll feed that back into you. And I think one final question here before we wrap up, probably coming your way, Lisa, which is that the distractions that services usually sort of recommend when you're craving a cigarette often are not things that people can be doing at the moment with our social distancing and the lockdown restrictions. So do you have suggestions for what services can be recommending to women that are sort of lockdown friendly distractions from those nicotine cravings?
I know that some areas have developed some brilliant top tips for dealing with lockdown, and we'd be very happy to share all of that. I think the main thing is to ask women what it is they are able to do given the current situation. Because although they're in lockdown, they're at home, they're stuck in with the kids, they'll have found themselves in that situation many times before when they wanted a cigarette. So I think it's about pulling on their past experience. And when people are really, really stuck of something to do, you can offer something on a menu. So it's still not telling somebody what to do because you get the ball thrown back, but giving them 3 or 4 ideas. So it might be using medication, calling a friend that could support them, finding something that helps them to be distracted or relaxed, even if it's just a walk around the garden or around the local block. But it's finding something that you can put on a little list and then just say, would any of these things help? So I think it is about finding alternatives, and we know that women aren't particularly very good in the more disadvantaged groups of coming up with things. But I think sometimes the more you try and suggest things, the more difficult the conversation becomes. So ask them what different things they could do. Have they ever tried anything before? Is there any other support around them that they could pull on? Because although they can't see family, they can call them. We know that medication generally isn't used enough for long enough. So often withdrawal and cravings and stress is linked to not using enough medication. So having a discussion around that. But certainly we do know some services have developed some great ideas, and I'm wondering whether we could access those and then put them out to everybody that's been on the webinar today.
Definitely, and yes, if anyone has top tips or things they would like to share, do send them in to us, and we will collate things and get that sent round.
I certainly have something that I'll be very happy to share and send over at the end of the webinar.
Brilliant, thank you, Lisa, and we will send that out.
Okay.
So that, I think, is bringing us to the end this morning. We're a few days over, but it has been a good discussion there, and thank you to our presenters for their brilliant insights. We'll be sending around a recording of the webinar, also the slides, and any questions that we haven't been able to answer or anything that pops up, do send additional questions through to us, and we will get them answered and send them out to you, along with the links to resources and additional top tips and suggestions there that Lisa has shared. So thank you again for joining us this morning. We've had our record-breaking webinar with over 300 attendees. So thank you all for your engagement and participation. And we will continue to be providing advice and resources over the next few weeks through the Smoking Pregnancy Information Network. So if you are not signed up already, do go on to the Challenge Group website online, and we'll send the link round for that as well. So thank you very much, everyone.